So, today we'll take up an approach to a case of hypocalcemia. Normal serum calcium level is 8.5 to 10.5 milligram per deciliter. So, hypocalcemia is said to occur when it is less than 8.5 milligram per deciliter. Now, before we start our discussion about hypocalcemia, we need to know about some important things. Pth hormone is the normal defense against hypocalcemia. Increase in PTH result in increase in serum calcium level and decrease in serum phosphate level due to its phosphaturic action. So the reverse happens if there is a decrease in Pth hormone level. That means there is decrease in serum calcium level and increase in serum phosphate level. Another important player in calcium homeostasis is vitamin D. Now, increase in vitamin D increase serum calcium and serum phosphate levels via increasing their intestinal absorption. So if there is decrease in vitamin D, so there is fall in serum calcium and serum phosphate levels. So with this background, let's go to our main topic, that is approach to a case of hypocalcemia. So ever you come across a patient of hypocalcemia, first correct for serum albumin, because hypoalbuminemia results in hypocalcemia. So the formula is serum calcium plus 0.8 into food minus serum albumin. So once you have calculated corrected calcium, exclude drug therapy, which can result in hypocalcemia. It includes calcium chelators, inhibitors of bone resorption, bisphosphonates and plicamycin, and drugs which alter vitamin D metabolism. An important drug in this category is phenytoin, also ketoconazole. Now, after calculating corrected albumin and exclusion of drug therapy, assess serum phosphate levels. Normal value is 2.5 to 5.5. If it is high, in the setting of hypocalcemia, if serum phosphate levels are high, so the most important cause is renal failure. So exclude renal failure. After exclusion of renal failure, AKI or CKD, assess PTH levels. As I have discussed already, that if there is a decrease in serum calcium and increase in serum phosphate, that suggests that patient is having hypoparathyroidism. So if the PTH level is low or inappropriately normal, that means you are dealing with hypoparathyroidism, which could be because of agenesis of parathyroid gland or acquired causes. Agenesis could be isolated or as a component of Digeot syndrome. Acquired causes, the important cause is surgical removal, radiation therapy, infiltration by metastasis and systemic disorders, and of course autoimmune etiology. Because hypoparathyroidism is a cardinal feature of autoimmune polyendocrinopathy. Now here I want to stress upon an important entity which is known as autosomal dominant hypocalcemia, particularly if there is a strong family history and early onset of hypoparathyroidism. It is a very close differential of hypoparathyroidism. It occurs due to activating mutation in calcium sensing receptor. So if there is an activating mutation in calcium sensing receptor, so it senses that the ambient calcium concentration is very high, which impairs PTH secretion. Supposingly this is a PTH secreting cell. There is a calcium sensing receptor. If the ambient calcium concentration is low, so the PTH secretion increases. Low serum calcium is sensed by calcium sensing receptor, and it in turn increases the PTH secretion. But if there is an activating mutation in calcium sensing receptor, so even in the setting of low serum calcium, it is sensed as high calcium state, so there is impaired PTH secretion. This is what happens in autosomal dominant hypocalcemia. And this calcium sensing receptor is also present in the renal tubules. So again, it senses that the ambient calcium concentration is high even in the setting of hypocalcemia, so there is impaired calcium reabsorption in renal tubules, resulting in hypercalciuria. So why it is important to exclude this condition? Because if you treat it with vitamin D analogs and calcium supplements thinking it to be hypoparathyroidism, so the patient is going to end up in irreversible renal damage due to formation of renal states. Because I've told you there is already hypercalciuric state, and by further supplementing vitamin D and calcium, you are exacerbating this state, resulting in renal stone formation and eventually irreversible renal damage. Now I think it is clear till now that if a patient of hypocalcemia with hyperphosphatemia in the absence of renal failure have low PTH levels, so the important causes are either hypoparathyroidism or autosomal dominant hypocalcemia, particularly if there is a strong family history and early onset. Now, if PTH levels are high in setting of low serum calcium and high phosphate level, if PTH levels are high, that means there is PTH resistance syndromes. It includes PTH receptor mutation or GS alpha receptor mutation, which mediates the signaling of PTH receptor. Now, collectively, it comes under the category of pseudo hypoparathyroidism. Pseudo hypoparathyroidism is of 4 types: 1A, 1B, 2, and pseudo hypoparathyroidism. I'll take up this topic separately in the subsequent part of the lecture. Now coming on to the another spectrum, if in the setting of hypocalcemia phosphate levels are also low, so assess serum magnesium levels. Normally it is 1.5 to 2 milliequivalent per liter. If serum magnesium levels are low, so hypomagnesemia attributes to the combination of hypocalcemia and hypophosphatemia. And mind you, hypomagnesemia is an important cause of many electrolyte abnormalities like hypocalcemia, hypophosphatemia, and hypokalemia. Now, how does it result in hypocalcemic and hypophosphatemic state? Hypomagnesemia, it results in impaired PTH secretion and also PTH resistance in bone. So it is very important to rule out hypomagnesemia and treat it in a patient of refractory hypocalcemia and hypophosphatemia. Now, if serum magnesium levels are normal, then you should look for vitamin D levels. Now, there could be three possibilities. Decrease 25 hydroxy vitamin D levels, decrease 125 dihydroxy vitamin D levels, or normal both 25 hydroxy and 125 dihydroxy vitamin D levels. So if there is a decrease in 25 hydroxy vitamin D levels which reflect the body stores of vitamin D, so that suggests that the patient is having nutritional deficiency or malabsorption states. If there is decrease in 125 dihydroxy vitamin D levels and normal 25 hydroxy vitamin D level, that means there is impaired 1-alpha hydroxylation of this compound. So that could be because of renal failure, because the 1-alpha hydroxylation result occurs in kidney primarily, or 1-alpha hydroxylase deficiency. And this condition is known as vitamin D dependent rickets type 1. Because you can treat it with active form of vitamin D, that is calcitriol. It is autosomal recessive. Now, if both 25 hydroxy vitamin D and 125 dihydroxy vitamin D levels are normal, or rather increased 125 dihydroxy vitamin D levels, then you should think of vitamin D receptor mutation. And this condition is known as vitamin D dependent rickets type 2, which is actually a vitamin D resistant condition. Again, autosomal recessive. You have to give frequent nocturnal calcium infusions to treat this condition. I think I'm very clear on how to approach to a case of hypocalcemia. First, you should correct for serum albumin level, then look for phosphate levels. Hypocalcemia with hyperphosphatemia, apart from renal failure, the classical cause is hypoparathyroidism. And hypocalcemia with hypophosphatemia, apart from hypomagnesemia, there is impairment of vitamin D axis. So this is the whole thing which you have to look for in a case of patient of hypocalcemia.